Hi, everyone, and welcome to yet another episode of our live series designed to help you take a step towards parenthood. We are going to be talking about the different causes of infertility today. And in our conversation, we have with us Dr. Ketki Mhaske. She is a consultant gynecologist, infertility specialist, laparoscopic surgeon at Lifeline IVF Center in Panvel, which has a legacy of 25 years and has delivered its 10,000th IVF baby this month. She also has a master's in embryology from the University of Oxford in the UK, a diploma in obstetrics and gynecology from Ireland, and a diploma in advanced laparoscopic and endoscopic surgery from France. Hello, ma'am, and welcome to our show.
Hello. Hello, Meghna. How are you?
Very well, and congratulations, for your center. We seeing that you're doing great work, and we would want to carry on a conversation with you today where we help couples sort of understand what are the reasons why they could be facing problems in conceiving. And I would like to start with just understanding trends in India. Do you think that in the past few years there has been a shift in statistics when it comes to infertility in India? Has it become more common now than it was, let's say, a few years ago?
Yes. At the outset, let me thank Hindustan Times for giving me an opportunity to share my views with you all. Yes, I would say statistically speaking, globally infertility is about 15%. Now, WHO gives you different statistics between 4 to 16% in India. But our own society, if you go to see ESAR, that is the Indian Society of Assisted Reproduction, which I'm a proud member of, we give it around the same as 10 to 15% in India. So if you see urban areas, it is about 1 in 6 couples have this problem, and it is much higher with metropolitan cities. And if you see the rural areas, now rural, it's less diagnosed, so I wouldn't get those right numbers over there. But yes, it has definitely increased over the past few decades. Now, if you see which one has increased, is it the male or the female, or is it both? So I would say the rise has been on the male side. So before about a decade back, I would say 40% of the males had problems. 40% was the male factor problem. 40% was the female. 10 was in both of them. And the rest of the 10%, I would say it was just unexplained. But now the shift has been towards the male side. It is around 50 to 60% of the patients coming in the infertility OPD with
Wow.
to us, it's 60% of are the male factor problems. So yes, definitely there is a change.
That's very interesting, right? Because whenever we sort of think, even just generally think of why a couple is seeking, help with IVF or just anything to do with fertility and infertility, we normally assume it's the woman. So for you to say that it's actually men and it's gone from 40 to 60% in the past few years,
Yes.
that's really a surprise.
True. Yeah, definitely. But that's a fact. That's what we see every day in our clinics.
So essentially, both men and women should seek treatment, and the onus should not be just on the woman.
Of course. It's an equal part. They have to be. They share equally to the embryo, so of course they would. Both of them need their treatments.
Okay. So can you also help us understand that what are the different types of infertility, or is it just infertility is just one thing and there are no classifications?
If you see, medically speaking, there are two types of infertility. So now I would say a primary infertility and a secondary infertility. So primary is when the couple has been living together, and it's a reproductive age group couple living together, trying without any contraception, trying to get pregnant for 1 year, and they're not conceiving. That is when I label them as primary infertility. And suppose if a couple has had a previous pregnancy or maybe a baby, but and trying for their second pregnancy, and then the second pregnancy they're again facing issues for a year, I would say that is secondary infertility. So just two types of infertility.
So, I mean, clearly, this 1 year time period of trying is important, right?
Very much. The couple needs to stay together and have a intercourse on a regular basis. Not that you have it just and the right timing, considering their ovulation. What a it has to be a good frequency of intercourse between the two of them, and giving them a proper chance, and then labeling them as infertility. The husband stays in Delhi and the wife stays in Mumbai for for a year, and that's not trying.
So it needs to be frequent. You need to know the right time. And if for a year, despite that, let's say you've not been able to conceive, then you do need to go talk to a specialist.
Yes, very much. Yes.
Okay. Can you also take us through, the most likely risk factors for infertility in both men and women?
But both, yes. First, so risk factors, yes, they're very important, because that is where you can yourself understand that I am at a risk of having infertility later in my life whenever I plan my pregnancy. So identifying the risk factors yourself is a very good thing. So first, let me just talk about the common risk factors between the male and the female. Both of them could have problems, which commonly is if their age is high, if they are on more than 30, 35, that's where then they might face problems when they try to get pregnant. Obesity, so if they're overweight with a BMI more than 25, 30, the risk of having infertility increases. Underweight people, both men, women, both underweight, BMI under an 18, they are at a risk of having problems. They may struggle with their fertility later. Alcohol, alcohol abuse, tobacco, smoking, illegal drugs. All these things are, now it's men, women, both, I would say, have to look into it, and they have to take proper precautions accordingly. Now, stress is one of the things which I would stress on, that stress, lifestyle changes, night duties, busy hours, sleeping for less than 6 hours in a day, all these, they contribute to your, you are having, that is one of your risk factors there and then, even if you plan pregnancy at the age of 30 and you are just 25 now. So previous infections, like if you've had sexually transmitted infections in the previous past and then you've been treated for that, you're still at a risk of having fertility problems later in your life. Diabetes, people on long-term medications, if you see people with the medications with arthritis or hypertension, these people, they might go in for problems with fertility, both men and women. If you go specifically towards the male, if he has a trauma to his testes in the childhood, has an infection in the childhood to his testes, that these are a few things which he should be aware of, that when they plan for their pregnancy, they should get themselves investigated earlier, not later. Steroid abuse in men, especially gym enthusiasts, bodybuilders, they steroid abuse is one thing which you have to cut it down. Men working in hot environments like furnaces, that's where again they are very harmful for the sperm. Taking really hot baths, frequent saunas is one more contributor towards infertility. Cyclists, they go for marathon cycling, they have those tight cycling tights, and
Yeah.
yes, so those tights are not good for men. They're supposed to, so those are
So
not
they look uncomfortable. I'm happy to know that they have other consequences too.
yes, and they do hours together, like 16 hours
Yeah.
of cycling, and those people actually come to us in our clinics that I used to do this, and now then there is no sperm count. The count is very low in these patients.
Wow.
uh, that's quite it with male. If you go to see females, what they have to be aware of, that I might have a problem with my fertility later, is if she's having irregular periods. Her periods are not always regular. She's having scanty periods, like really less bleeding, just a day or two, and that just increases things. If she's had a history of tuberculosis in the past, and treated, untreated, anything, but tuberculosis is one of the major reasons in India for fertility. It has come down now quite a bit, but still, I wouldn't just disregard it. It is still there. If the female has had a previous pregnancy in her tube, that's called an ectopic pregnancy. That is one of the reasons where I would be worried about her future pregnancy. She needs to seek help earlier. previous septic abortions, if she has had any abortions, again, sexually transmitted diseases like chlamydia, previous pelvic infections. She's had ovarian cysts, something when they do a general scan and they see, oh, they have a cyst, then that is one of the risk factors. She's a diagnosed PCOD. So diagnosed is she's been to the doctor, seen it. The doctor has labeled her that she has a polycystic ovarian disease or a syndrome. So that's when she's diagnosed. She should be aware. Her gynecologist would always tell her that you would have problems with your fertility later in your life whenever you try to get pregnant. So these are the risk factors they should keep in their mind before they go into plan a pregnancy.
Okay. So you were talking about sexually transmitted infections right now. I also want to understand, can viral infections, given that we're in the middle of a pandemic, can viral infections also have an impact on fertility, particularly, of course, COVID-19?
Uh, COVID-19, I wouldn't give it. We really know very little about COVID-19. How it has affected someone's fertility, we wouldn't know. But when patients come to us and they ask you, okay, I've just recovered from COVID, can I start planning my pregnancy? We say, so if you've had so many drugs in the last 2 or 3 months, in the last month when you were suffering from COVID, so with COVID, you do antiviral drugs, you do steroids, and those are things which we would avoid before you get pregnant. So we ask them to wait for a little while, just give it to yourself 3 months at least after your rigorous treatment for COVID, and then you can start off when you are back to your normal life. uh, Especially the medical reason I would say for this is, so today if a sperm is made in someone's testes, or today if the eggs are made in someone's womb, they in their ovaries, they're released after 3 months. So their cycle
Okay.
is of 3 months. So once their cycle is of 3 months, we should, if you provide them with proper nutrition and proper environment for growth, so you get good quality eggs and you get good quality sperms, eventually you get a better pregnancy rate. So we give
Okay.
them 3 months. So prep yourself 3 months before you want to get pregnant.
So take care of your body during those 3 months before you start preparing for a pregnancy.
Definitely. Yes.
Okay.
Yes.
Absolutely. So, I have a follow-up question on this. You had also mentioned a while ago that for women, a biggest risk factor could be irregular periods. Now, that of course could be because of PCOD or something else that she's diagnosed for. Many women are also reporting that their periods become irregular after they get COVID. Of course, we don't have a large data sample for this,
Yes.
but there
Yes.
is a lot of women have started complaining about it abroad as well as here. Do you think there could be a connection there?
Now that could be the connection is we don't have any data as such saying that COVID, the virus, infects or has some problem with the uterus or the ovaries. Has that done anything to the ovaries? At least I'm not aware of. If it's in the process of publication, I have no idea. But there is no direct effect on the ovaries or the uterus as such at present. But the medications which you go on through, the steroids, the antiviral medicines, many other medications, and finally your body is under stress when you're going through COVID. So these are the 2 or 3 factors which can change your periods for a while. You might recover after 6 months. This is just a temporary way of saying that body is still recovering.
So no need to panic. Your fertility in all likelihood has not been touched. Give your body some time to bounce back.
Exactly. Yeah. Yeah.
Okay. All right. So now, we started this conversation with how we always think that there is the onus of being the fertile womb is, or being infertile is on women. What would you sort of say, is the diagnosis method for infertility in both men
Oh,
and women?
okay. Before that, can we go to the causes and then I will move to the this?
Sure,
I thought
absolutely.
after the factors because our topic is causes, so I thought let's just go with causes
Sure,
first.
sure.
So
Absolutely.
what I discussed was the risk factors. Now I just was waiting for the causes because causes is something which I know not people and not you cannot correct it yourself, but there are some things which where you need the doctors to intervene and correct it and help you go through your fertility smooth.
Hmm.
Let me just go back to causes and then I'll come to your diagnosis
Sure,
question.
absolutely.
So and we'll start with men because men have more infertility these days than women. So we'll start with men
Okay.
now. Okay, so with the men, if we see sperms, that's all we need from them. So the
Hmm.
sperms, we need a good quality sperm, we need good quantity of sperms, and we need a good motility of these sperms. So now there are medical terminologies, many medical terminologies where you would define these things. So men would have azoospermia, which is no sperms at all, oligospermia, which says less number of sperms, teratospermia, where the sperms are abnormal, they are abnormally shaped, and then they
Hmm.
cause problems getting pregnant. Then there is asthenospermia, where the motility. So the sperm has to travel right from the vagina into the
Hmm.
uterus and into the tubes where the egg is waiting for it. So that's
Hmm.
his journey. And so if you have a good motility, that's when pregnancy can happen. Otherwise, it's just very difficult. So the motility in these sperms is very important. So if these things are hampered, that is one of the major causes of infertility in men. Then there are other things, as I discussed, STIs and varicoceles. There's a sometimes now there's a psychosexual problem called erectile dysfunction, where the man cannot sustain an erection for a longer time, and
Hmm.
that leads to sometimes there is ejaculatory failure where he cannot deposit his sperms into the vagina.
Hmm.
Sometimes there is a case. One of the reasons would be there's one. Sorry, let me get back to it. Yeah, the cause. One of the causes for infertility would be retrograde ejaculation, where the when the men climax, they cannot get the sperms out. Rather, they go back into
Oh.
their bladder,
Oh.
their urinary bladder. Yeah, so this is
Hmm.
one of the reasons where infertility arises and
Hmm.
pregnancy doesn't come out. Then there is something called anti-sperm antibodies in these men. So, like people with thyroid dysfunction, there are
Hmm.
people, your own body is producing antibodies against your own gland, thyroid gland. With these patients, the sperms are being attacked by the husband, the person's body itself. So they are making antibodies. You yourself are making antibodies against your own sperms. That is one of
Hmm.
the reasons with infertility in men. Uh, yeah, with men, I would say this is it. There is one more thing which we've recently found a test also for that. It's called DNA fragmentation. So every
Hmm.
sperm have a DNA in it, which is
Hmm.
responsible for the life. So the DNA is fragmented. That is, it's abnormal, and it doesn't make the right embryos or the right babies. So that's where we have to. That is one thing which can be diagnosed with a test, which we're coming up to later. I'll be talking about it
Hmm.
in detail.
Hmm.
And now we come to women. So women have three parts: the uterus, the ovaries, the tubes. Any problem with any one of them is going to mess up fertility problems. The uterus, if there is fibroids, there is endometriosis, that is the lining of the uterus, which you shed every month during your periods. If there is an infection of that, yes, it can cause problems with your fertility. Uterus can be also when you were born. Suppose it's
Hmm.
congenital, say. So the uterus can be funnily shaped. It's either a bicornuate uterus or a unicornuate uterus, or there may be a septum in the uterus. These things interfere with your fertility. There comes the ovaries now. The ovaries, as we discussed, PCOD is one of the major problems
Yeah.
where there's a small gland in your brain which starts secreting hormones, and the ovaries
Hmm.
work are dictated by the gland. So if there is any problem with these hormones secreted by your pituitary gland, the ovaries
Hmm.
start acting funny, and they don't respond in the normal way.
Hmm.
So PCOD is one of the reasons I would say for female infertility when it comes to ovaries. And then ovarian cysts, endometriosis is one of the conditions. Now, endometriosis, I'll just speak a little bit about it. That
Hmm.
every month when you get your periods, you shed a lining of your uterus. So that lining, by some cause, is deposited into your ovaries. And every month when you bleed from your uterus, you're bleeding into your ovaries also, and they form cysts. which are
Hmm.
filled with blood, and they're called chocolate cysts. It's a very
Hmm.
common terminology when we use in infertility. So you find chocolate cysts is another reason for infertility in women due to ovarian dysfunction. So ovary is not doing well. Then comes the last but not the least tubes, the fallopian tubes. Now they are the
Hmm.
ones which connect the uterus and the ovaries. Anything going wrong with those fragile organs, it can be really messing up the whole cycle.
Hmm.
So if they are infected due to some inflammation or some infection of the pelvis, they tend to get bigger. They're swollen, and there's a fluid filled in that. So if that thing happens, there is no connection between the sperms and the eggs from the ovary,
Hmm.
and that causes no fertility. So that causes problems in your fertility. So, previous ectopic pregnancy where the tubes have been
Hmm.
damaged, again, she will have problems with conceiving. So these would be roughly major causes. Now, if you see, centrally speaking, thyroid patients, they struggle with their
Hmm.
fertility. If they have thyroid dysfunctions, they do struggle with their fertility. Um,
Okay.
that's quite it. Yeah.
So you had also spoken about abortions. When we were discussing the risk factor, can you tell us a little bit about how abortion would impact, the reproductive system for a woman? Also, because from what I understand, there are two types of abortions. One that is done with a pill, and another which is, surgical. So both
Yes.
have equal, do both pose
Uh,
equal risk?
no, I wouldn't say surgical or medical would pose any risk at all. Abortions are completely normal, but I was talking about septic abortion. So,
Okay,
septic
septic
abortion,
abortion.
yes, when it is not done in a proper way, in the
Hmm.
proper manner. So, if you go to a center and get your abortion done, probably they cover you with antibiotics, they give you proper treatments, and then
Hmm.
there should be no problem having abortions. Abortions will lead to infertility. No, that is not the reason.
Okay.
If you have an infection there, if you catch up an infection of your uterus up in there, that's called sepsis after an abortion. So
Hmm.
the septic abortion would cause problems, but just a
Okay.
routine abortion wouldn't have any problems. I wouldn't give that.
Okay. All right. Before we go on to diagnosis, I also wanted to, ask you as to what your advice would be for both men and women as to what they can do to sort of prevent infertility to whatever extent that they can.
Yeah, preventing, that's what risk factors, that's what we discussed about. So, risk factors identify, see, people are educated these days. They know what is going wrong, what is right, and what is wrong.
Hmm.
So, just lead a life which is a healthy lifestyle. Don't be overweight. Try to keep your weight in control. Alcohol, tobacco, smoking, other drugs, cut it down. Just try to maintain a very healthy lifestyle with whatever conditions you have. Even previously, if you have diabetes, try to keep it in control. All these things, and you will help yourself and us also. If in case if you want to come to us, you will help us also. So it is.
Yeah.
It's just that lifestyle changes are very important. Stress. Get rid of stress. Have your own time with your family, for your hobbies. Keep some times aside for hobbies. That makes you. That makes you free from fertility. I wouldn't say that infertility, but it does help you in the long run. Yes.
Which would also mean that, when you do visit a specialist, you would have, let's say, better chances of conceiving with some assistance.
Very much, very much, very much. So you would require minimum assistance from us.
Hmm.
You would
Hmm.
be yes, and sometimes when people lose their weight, like patients with PCODs, they
Hmm.
lose weight. Even if they lose 5% of their body weight, they conceive naturally sometimes. So
Oh,
we've seen those results, yes, in patients who just tried 5% and their fertility improved. They've conceived naturally. So it just makes a lot of difference. Yes.
that's actually very heartening to know because, PCOD, so many women suffer from it, then it becomes a concern when they get married.
Yes, very much. No, no. There are patients who conceive on their own. They don't even realize that they were PCODs.
Hmm.
It just
Hmm.
goes on. Yeah. So weight loss and control, having a good lifestyle, yeah, does definitely help you.
Okay. So now let's come to the diagnosis part that how can, infertility be diagnosed in both men and women?
Yes. So diagnosis again. Let's start with men. Simple tests. semen analysis. That is, they need to give their semen, test the semen
Mhm.
analysis.
Mhm.
Hormonal investigations, that is their thyroid, their prolactin levels, their blood tests, just routine blood tests of hemoglobin and HIV, HbSAg, all those things. That's what we do with men. And on the semen, so we do a DFI, that is called a DNA fragmentation index. As I told you, so if their DNA of the sperm is not good or is abnormal, that's when we do this test, just to find out if there's a lady who's having repeated miscarriages.
Hmm.
Then sometimes it is the problem with that sperm or the DNA of that sperm. We go and we ask them to get that test done. So a good value is once we get that. Now there are not proper medical therapies for that, but some
Hmm.
adjuvant therapies, just some supportive therapies, give you a good result in patients who have a poor DNA fragmentation
Hmm.
index. So that is one of the tests which I would add in these patients. With females, yes, we can hormonal studies. So there are hormones which are FSH, LH hormones, prolactin, thyroid hormones, very important.
Hmm.
The most important in them is the AMH, that is called the anti-Mullerian hormone. Now, AMH is the one which tells you about the, the capacity of producing eggs. What is the egg generating capacity of that
Hmm.
female? Because your eggs are fixed when you are 1 year old. So when
Hmm.
you were born, you have the fixed number of eggs, and that's what you have to go on with. Men, on the other hand, have new sperms every 3 months, but we don't. So that is very important. Once you have those, you know what kind of a fertility this lady can achieve. With female, that's quite it. And then we do a sonography for just to see her uterus, her tubes, her ovaries. Patients who are suffering with infertility, all these things are normal, and they're suffering with infertility problems. She's under 30. I would just get a sonosalpingography done for her.
Hmm.
That is where we try to push in just normal saline from the uterus, and with the sonography we see if it's coming out of her tubes, just to see if the tubes are patent,
Hmm.
working. So can we establish a connection between the egg which is released from the ovary and the sperm? And that's what we do see. Again, an advanced investigation for the female would be diagnostic laparoscopy and hysteroscopy. So that is where we put in a small telescope through the belly button of the lady. Now, definitely, she's anesthetized. We see her
Hmm.
ovaries. We see her ovaries, her tubes, her uterus from outside, and we put a similar telescope from under, that is from the vagina into the uterus, and see the cavity. So if you have
Hmm.
a nice hollow cavity where in the baby if it is adequate for the baby to grow in or not, we see the endometrium, the thickness of the endometrium where the embryo has to stick in, if that is good or not. And so this is what we do for a patient with fertility problems for longer term, like maybe more than 5 years she's been struggling. That's when
Hmm.
and a younger patient, that's when we would go for a diagnostic laparoscopy and a hysteroscopy in these patients. So it is again a diagnosis phase, it is not a treatment phase.
Hmm.
So in case if we find during this laparoscopy, if we find there is a fibroid or a polyp which is causing problems, we go in and treat that there itself. So
Okay.
it's done in the same sitting. So
Hmm.
diagnosis, do the diagnosis, fine. You see there's a polyp, take it off. You see there's a fibroid which is going to cause problems, take it off. You
Hmm.
see that the tube is blocked, try to open the tube with a tubal cannulation. If you see the ovary has a cyst, take it off. So that just helps in the further
Hmm.
processes for these patients. So we do diagnostic, and then if need, we correct it.
Okay. So there, it's safe to say that there are a lot of options that no matter the problem that you might be facing, which is causing, let's say, fertility issues, for
Mm.
both men and women, there are plenty of options to understand the problem and give some treatment, even if suppository, to ensure their chances of conception.
Yes, of course.
Okay. So once diagnosed, what should be the next steps for a couple? And in what scenario is IVF, advised to patients?
So once diagnosed, it all depends upon what has been diagnosed. So what is the age of the patient? What is the age of how long they've been trying for getting pregnant? So if you divide them into people under 30, people under 35, and people under 40, I would just that's where people try to go in. So if they've had someone who's under 30, been trying for 2 to 3 years, we do help them out with smaller medications, just oral medications and smaller investigations, and try to get them sorted with minimal intervention. But she's more than 30, trying for more than 5 years, then we do advise them laparoscopy and then followed by an IUI. So IUI is something which is where we take the sperms of the man and we give the female some tablets or some injections to make eggs. And then on the 12th day, we give her injections for the egg to rupture, just to come out of the ovary and wait in the fallopian tube for the sperms to meet them. And then we take the sperms of the man for the male partner, and then we we actually make the motility of these sperms a little higher. We process it in the lab under certain conditions and take the best of the sperms and push it into the uterus of the female. That is the whole process of IU. I know it is a different topic altogether to be speaking, but yeah, that's what we plan to do with these patients. With long-standing infertility, patients have been trying for more than 8 to 10 years. She's tried a few things. She's tried IUI. She's tried many other things. She's more than 35. AMH levels are low. Something which you cannot point out that this is the problem with her. That's when we tell her IVF. So that's when we go for IVF. Otherwise, if it's if it's just a short infertility, we definitely try with minimal interventions. We wouldn't go straight away to IVF. IVF is after a lot of trial because it is a commitment. It is not it is not a straightforward answer to questions of fertility. It is a commitment. It is 1.5 to 2 months procedure where it takes a toll on the body of the female, emotionally, financially, everywhere. It is stressful. So yes, we do it as a later end stage thing.
Okay. So IVF is not what happens immediately. Your doctor will obviously assess. They'll see what is your age, how long you've been trying for, what are your problems, what are your needs, and then decide what can be done for you, then be it IUI or IVF or something else altogether.
Yes, of course. Yeah. There are many things which you can. Yeah.
Okay, so with that we come to the close of our session, but before we call it a day, I would want you to sort of give the couples or men and women watching this some advice who might be sort of grappling with infertility. What would be your advice to them?
So I would definitely say you're all educated, you know what is right and what is wrong for your body. Don't take fertility for granted. It comes very naturally to people. Some people might come naturally between two sisters. One must be really struggling and the other must be having kids one by one every year. But so just don't take things for granted. Look after your body. If you think that you might have problems right now, as we spoke about the risk factors, just go to a doctor, get that sorted, and keep it at the backhand that okay, fine, I'm sorted with this, and now I can wait for another 2 or 3 years. Don't wait too long before going and approaching a specialist. It is always better to go and approach a specialist and get your things in order.
Okay. All right. Thank you so much. It was a real pleasure talking to you. This was such an insightful session.
Thank you so much. Thank you.
Thank you and have a nice day.
Thank you.